We've become quite interested in cancer cachexia at Rush University Medical Center, and the reason is, I mean, all of us who take care of these patients know that it's very, very common to see patients suffer from the anorexia cachexia syndrome. They lose their appetite. Here we say 70%, but I would say virtually every stage 4 lung cancer patient goes down the road where they're going to die unless they have some sudden event. Virtually every single patient faces some element of this. It's characterized by decreased appetite, food intake, loss of body weight, and in particularly lean body mass weight is a key thing. And actually, ECOG was one of the first groups that really started to look at this. Bill DeWeiss, who was at that time, who was the director of Hem-Onc at Northwestern University, he decided to look across many ECOG studies, over 3,000 patients, and he saw that weight loss was associated with poor performance status, increasing number of metastatic sites, and as most importantly, and sadly, with shortened survival. Well, the dominant feature of this syndrome is really loss of muscle mass. And for years, I listen to the patient, he or she is telling you the diagnosis. I learned that in medical school. I don't always pay attention to it, unfortunately. But I'd have guys come in, big guys, and say, "Doc, my arms are gone, my legs are gone." And it's because their muscle mass was just melting away. And it cannot be reversed by nutritional support. You could do hyperalimentation, you could do enteral alimentation. What do we tell our patients? Well, eat small feedings more often. Breakfast is going to be the best meal. Dinner is going to be the worst. Try to work with that. But you can't overcome it. You can help ameliorate some of that discomfort and the distress that they have, but you can't overcome it by just giving nutrients. And here's something that's, again, going back to the, the muscle that we're talking about. The red is the cross-sectional trunk muscle mass. And the first patient is actually a little bit overweight. BMI is 25. And you notice on the left-hand side there, very high skeletal muscle index and one kind of in the middle. And on the right-hand side, it's actually low skeletal muscle index, even though the patient is a bit overweight. You know, this is important, I think, because some of the current guidelines say, you know what, if you're giving chemo, giving cytotoxic agents, base the dose on the actual weight. Well, I believe, and we don't do that, I believe that patients who have skeletal muscle mass loss and are obese, if you give them the full dose based on their body weight, they're going to get really bad side effects. And now, we don't measure the skeletal muscle index. How do you do this? Well, you can do it on a routine CT, but you have to have a special software called Slice-O-Matic, and it takes quite a while to do it. We do it in our research studies. We don't do it in the patients routinely. And so a low albumin would be a hint to that. You see an obese patient with low albumin, think twice about giving them the dose based on their full body weight. We come to the lower panel of scans there. We see that skeletal muscle index is a little low. Below 55 is low in men, below 39 is low in women. And here again, you see a person with a high BMI, kind of a medium BMI, and a low BMI. BMI 18.5 and less, or some people say 20, that is cachexia if you have a BMI at that level. But here again, we see that the BMI, even they have that low muscle mass. The patient on the left-hand side, if he gets full dose, I think is at risk for getting bad side effects. Probably there are many things that are involved in the syndrome. People can't eat as much. They're weak, they're tired, so they're not as active. That helps muscles, unfortunately, muscles to disintegrate. But the real thing that drives this probably is inflammation, and probably trying to target those mechanisms and figure that out is a way that we can really help to make patients feel better. And we actually think possibly also go hand in hand with the therapies and possibly see longer survival, like the things Dr. Hirsch saw. I thought very interesting, these studies with zoledronic acid, that you see patients actually living longer. It's not just controlling the bone mets, but it probably is doing something to the cancer. So and I think the same thing is true here. If we can treat cachexia, and that goes hand in hand with the systemic therapies that we do, it's going to help patients live longer. That's our hunch. This is Dr. Ken Fearon, surgeon from Scotland, and I want to just take a note here to pause that sadly, he passed away very suddenly about 6 months ago. But this man is a pioneer in this field. Been studying it for 30 years. And in one of his reviews, this one, Nature Reviews Oncology, he just points out, if you look at low skeletal muscle index, the hazard ratio, the rate of dying from any cause goes up. So people who are frail, they're more likely to die. What other people are frail? COPD patients are frail. They have cachexia. People with chronic renal failure, rheumatoid arthritis. Many diseases are associated with this wasting syndrome, and it has a big impact on how patients feel and how long they live. Here's the other thing, is if you have cachexia, or in this case it's just pre-treatment weight loss, and we're looking at some cytotoxic agents here, pyrimidine, and I think it was a gemcitabine, that patients who had weight loss, they got a lower dose and they got more toxicity. Certain toxicities were increased. So people are losing weight or have lost weight or have the cachexia syndrome, more likely to have side effects. There isn't very much data about this. This is a couple of the few papers that show it. We need more data about this. And then the next one is, whoops, not going forward here. There we go. So even targeted therapies, in this case, sorafenib and afatinib, some folks looked at patients who had pretreatment sarcopenia, and they saw that the dose-limiting toxicity was greater in the patients who had sarcopenia. So cytotoxic agents and also chemotherapeutic or targeted agents. Now, this is a paper with a small group of patients, but it caught our attention. It's a French group. And they're looking at a way to define which patients get benefit from the new targeted therapies, immune checkpoint inhibitors. And basically, it wasn't big. It was 250 patients, many tumor types. Melanoma was the most common. Lung was only about 10%. And they found three things. They looked at high tumor burden, which they defined as resist some of the diameters greater than 9 centimeters. And in this case, they call low skeletal muscle index less than 53 centimeters per meter squared, and also the presence of non-pulmonary visceral metastases. And if they look at it, the blue line, if they had none of those, that's the survival rate for the folks who had none of those factors. If they had one, drop to the green, two, yellow, and if they had all three, the red line. And it kind of fits with something we're looking at in our patients right now who got immune checkpoint inhibitors. Our hunch is patients with weight loss, patients with cachexia, do not seem to do well on these. And again, they don't do well on cytotoxics. But with targeted agents, that doesn't make any difference. Corey referred to the Lazarus stories we sometimes see. We'd have patients with tremendous weight loss, performance status 3. You put them on those, they get reversed. Cytotoxics, they usually can't tolerate it, or we don't even try to treat them because we think it's going to be too difficult and not likely to work. But it also suggests with immune therapy, which in general, the single agent immune checkpoint inhibitors have been easier than chemo, every study that's been looked at. But patients may not be able to mount a strong immune response if they're cachectic. Again, this is just a table from that paper, and the key thing is SMI by itself was a single variable that was associated with worse survival, a hazard ratio 1.6 and a p-value of 0.03. So something to look at. Can we reverse cachexia, and can we make these immunotherapeutic agents work more effectively or work in that group of patients? So what are the effects of cachexia? Obviously, weakness, fatigue, emotional distress. And we're going to talk, we heard that in Beth's talk. One of the things that we hear from patients and their families when we're seeing them in the exam room is the families are very distraught because the patient can't eat. They're trying to help their loved one. They make everything they can. They think it's his favorite dish, can't eat it. Huge emotional distress within the families and for friends who have patients who have cancer-related cachexia. Increased toxicity, and we think maybe impaired immune response. Well, what strategies reverse it? Well, one of the things, and surprisingly fairly little has been written about this, but effective cancer treatment can reverse it. We try appetite stimulation, we try to inhibit inflammation, and then newer approaches. So this is a paper that Jyoti Patel published a little past summer, and it was looking at 2,300 stage 4 lung cancer patients who were getting first-line platinum-based regimens. and the median age was 61. Most were, they're all 0 and 1, no 2s. And what you found is 18% of these people gained 5% or more of their starting body weight. And if we looked at the survival, the dotted line there is for those who gain more than 5% body weight, significantly better, with a hazard ratio of 0.57. That's the type of hazard ratio we like to see with treatment. And the interesting thing is even any weight gain, a pound or two, hazard ratio is about the same. And maybe it's because even stabilization of weight while they're being treated is also associated with a better result. We think because the cancer is being controlled. And the other interesting thing is they looked at those who gained more than 5% body weight versus less, and the response rate to chemo was roughly double, 50% versus 25. Disease control, if you include stable disease, 91 versus 63. We would like to say, oh, that means tumors shrank and therefore people gain weight. We couldn't really do that, though, because the weight gains were the maximum weight. It wasn't at a specific point in time, and we didn't know necessarily if they were right in remission at that time, so we couldn't do it. In our in-house studies, we're working on that right now, and we hope to see if our hypothesis is supported. Well, we know there's a lot of appetite stimulants. We all use these in treating our patients. Glucocorticoids can stimulate appetite in some patients, but they're associated mostly with fat gain. Edema is also a problem, and I think the biggest problem with these treatments is proximal muscle weakness. How many of you have seen a patient said, Doc, I can't get out of a chair anymore, or it's hard to lift my leg to go up a stair when they're on steroids? We see that we use the steroids, but we see this all the time, and it's a problem. Same thing with progestins. Again, they can increase appetite and weight in some patients, but overall they've got drawbacks, and one of the particular ones is thromboembolic events. Marijuana, a lot of people tout this, but the studies really don't bear it out in cancer patients. Also, an interesting thing from a very old paper, a small paper published by a Scandinavian group, the use of indocin versus placebo in all types of cancer was associated with a longer survival. So maybe inhibiting inflammation may actually help patients to live longer, but we haven't been able to show that with newer things like Celebrex, celecoxib, that didn't work out. But maybe it has to be specific subsets of patients. So some of the newer things, enobosarm is a selective androgen receptor modulator, which has been shown to put lean body mass on patients, but it did not, lung cancer patients in particular, but it did not improve performance to climb up stairs. And as far as I know, that development of that is not going forward. Anti-IL-6 is being looked at, anti-myostatin, and then anamorelin, Grelin, the agent which is farthest along and hopefully getting approved to help treat cachexia. And Corey referred to the Romana studies. There were 2 of them. They were international studies. They were looking at the compound anamorelin, which is an oral agent, which is an analog of a hormone made by the stomach lining called Grelin. It binds to the Grelin receptor in the brain, stimulates appetite. It also stimulates the release of growth hormone. The study was a 2-to-1 design, and so 2 patients out of 3 would get anamorelin, the other third would get a placebo. Patients can have any kind of treatment or even no treatment. 10% of the patients had no treatment. Some had only radiation, some had chemo, and they could get into this study. The endpoints were lean body mass, which was measured by the DEXA scan, and hand grip strength, and these measurements were done at 6 and 12 weeks. And this was a question that was a little bit difficult, having to know the actual number of the change in the lean body mass, but it's 0.44 decline in Romana 1 with an increase of 1.1 if they got anamorelin, and in the other study, a decline of 0.96 versus an increase of 0.75, highly significantly different, but not an improvement in the hand grip strength. And so a question is, and I don't know the answer to this, but can someone gain weight without training? Can someone gain weight just by putting muscle mass on? My hunch is you got to train. I do a little bit of exercise, not much. If I have 4 to 6 weeks where I'm away from it, I do not come back at the same level. So I think you have to have training. Again, here we also see that body weight improves significantly with anamorelin, and the anorexia cachexia symptoms measured by the FACT instrument for that also improved significantly in both studies. Fatigue was not improved. And this shows how rapidly the change in body weight happened. Even at week 3 in both studies, we started to see the weight, and then it was maintained and increased, actually. And same thing for the symptoms of anorexia, cachexia that were measured by the quality of life instrument. Very, very quickly, the first evaluation 3 weeks later, already better. Fairly little side effects with anomorelin. There is sometimes a little rise in blood sugar. Was not a major problem, but overall it was really quite easy. Overall, survival, really not different. Now keep in mind, the patients in this study only received this for 3 months. And again, I wonder, and this is my personal opinion, if patients were treated for a longer period of time, maybe continuously throughout the course of their cancer, might they live longer if they had this agent that was inhibiting the mechanisms of cancer cachexia and reversing the muscle mass. Don't know if that'll be the way it works out, but that's a question I have, and I hope in future studies that'll be addressed. So this syndrome is very, very common. All of us see it on a daily basis. The main feature is loss of lean body mass. Along with that comes weakness and fatigue, more toxicity, and we think maybe might even impair the ability to mount a good immune response. 2 agents have shown increased lean body mass increases, anomorelin and enobosarm. Anomorelin, there are additional studies in the works. Enobosarm, I think not. And anomorelin not only increased in lean body mass, but also reduced the anorexia that patients had. Thank you very much.